For those of you who are coming to this for the first time, these are a few talks that we're doing on thought leadership. And I'm really pleased to introduce our next speaker, Tracy Cannell, who's the Chief Operating Officer for Tower Hamlets Confederation, or Federation even, who's going to be talking about the innovation at the speed of trust, which is a fascinating topic. I'm really excited to hear this. So Tracy, thank you.
Thank you. Nice to be here this afternoon. In terms of me, I say I'm Tracy. I've been working in Tower Hamlets now for about 2.5 years. I'm an NHS person through and through, and I've worked in acute, community and primary care, as well as learning disabilities all my life. And Tower Hamlets is one of the most fascinating and interesting places I've ever worked in. If you don't know Tower Hamlets, it's that little blob there, and if you ever watch EastEnders on television, if you ever see that, then it's the area that's featured there. And it's tiny. Its area is literally about 7.5 miles square, so it's absolutely tiny. And the contrast of the place is quite amazing. We've got, the name comes from the Tower of London, which was built in the 11th century, which sits over in one corner of Tower Hamlets. But it goes and it encompasses Canary Wharf, which has got the big financial areas, and then it goes up as far as the new Olympic Park. The population at the moment is around 306,000, but it's due to grow to probably about 360,000 by 2026. And the population's quite young, but it's got huge levels of deprivation. It's got the highest child poverty rate in the UK. Its mix and diversity is quite enormous. It's got around about a third of the population is Bangladeshi, and a third are white British, and then it's got around 60 to 90 languages that are spoken in the area. So very different need, and the level of movement of the population is quite amazing as well. It's about 20% people churn to come in or move out of Tower Hamlets every year. So the range of what we have to deal with in terms of a very, very poor population, but then respond to this very different affluent group that move in from around the world is quite different. These are some of the pictures that if you've ever been, you might recognise, but you've got Brick Lane, if you heard of Brick Lane with the Curry Mile, yeah. You've then got Canary Wharf down here, which looks very, very different to what's actually mostly in Tower Hamlets, which are old flats. And then you've got these lovely canals that work and go all the way through Tower Hamlets, and some great parks as well. So it's a really interesting place to work and live, completely different in a very, very small area. Some of our challenges that we face are, say, really stark in terms of our life expectancy. And if you live in the UK and you hear somebody from the NHS speak, they'll always talk about, we've got one of the most deprived wards in Britain. Well, actually, we can top all that, unfortunately. And one of the very, very sad things that I find in managing children's services as part of what I do is that I have never seen so many deaths of young babies so frequently. In fact, we've had one again this week in Tower Hamlets, and that's a tragedy. So we've got lots of challenges, and what we've realised is that actually the answer to these is not just looking at health, but it's looking at the wider determinants of health and working together to solve what is a system issue. So what we do, I'll get this one to work, is work together, and I just wanted to show you and to give you an early story of success, really. So we've been working together for quite a long while, and here what you see is one of the markers we look at is how many unplanned admissions, emergency admissions, do we have in Tower Hamlets compared to what you would expect. And we've been quite high, and we were plotting originally higher than what you would expect given the nature of our population. But we started working together quite a while ago now, and we're starting to see some success of that. So if you look at the red line, that's Tower Hamlets and our emergency admissions. And then you look at what you would expect naturally, and we are definitely on a path downwards. It gets a bit skittish, and whenever you get to winter time, it starts going up a bit. That's life. But we are tracking downwards, and we're now starting to see, although it doesn't necessarily show very well, a real statistical difference in what we're doing in terms of its impact. So I think this one shows a little bit more as well. We work together as a vanguard project, which has got some special focus from the government in the UK. But this shows where we are in terms of our emergency missions compared to other projects which have got vanguard funding from the Department of Health and NHS England, and then where others are. And we are tracking well below what you would expect. Why is that important? Well, it's an indicator of how well we're doing in terms of impact, but also the more we spend on acute unplanned care, the less we have to spend on other things. And that's quite important to us. So down it's going. So that's quite good to see. How are we doing it? Well, this is where it's about trust and innovation at the speed of trust, really. How do you, because it's, as I say, it's not a health problem, it's a system issue. And so how are we working together? Well, what we've done in Tower Hamlets is we've brought all of the relevant agencies together, so health, education, social care, and also the voluntary sector. And we formed a board which has all those partners on it, and there's 2 representatives from each organisation on one of those. And what we've done is we've worked with our local population, and we have a stakeholder council, to look at what are the outcomes that they would like to see. So we've got a series of I statements from them about what they would like to see in terms of their lives in Tower Hamlets, which we've adopted and accepted and agreed as a partnership that we will focus on achieving improved outcomes for them that they'd like to see. And we've learned a lot of things about our population on the way. So even though it's very small, and I have to say, having worked in more rural parts of the UK, in Tower Hamlets, the transport system is fabulous. We've got something called the DLR, the Docklands Light Railway. We've got most buses you can see from one bus stop to the next. And the number of buses are amazing. And we've got the tube as well. And it's not very big. However, our population will not move beyond 500 metres from where they live. So, which I still find incredible, but at the same time it means that actually our do not attend rates, so people who have appointments and should and have agreed to hopefully attend those appointments, don't go. So our DNA rate for all services very commonly runs between 10 and 15%. So if we want to work with our population successfully, we need to look at how do we work with them in terms of understanding that partnership to agree with them ways in which they will access services successfully. So there you've got some of the other things that we're looking at in particular, and we've focused on how do we develop that partnership between us which focuses on those outcomes. And one of the key things is around data and analytics. So I think we're the first in the UK, I was talking a little bit earlier, to develop a data set which includes at a person level all their data from both health and social care. And we've just got all the permissions to do that. It's taken us 2 years. And so we're now ready to use that. So we can really do some proper risk stratification and start planning things which are very specific to different areas. We're looking at how do we pay and reward our services for what they do, and how do we reflect more accurately and stop some of the perverse incentives around some of the pricing that we have. And governance, we actually have brought together all our organisations into a system so that we have a joint patient safety committee and we have a joint systems management committee. So we look at how we're doing things and how well we're doing things together, and we share and learn. And we train all our staff together. We have training sessions which are specific to Tower Hamlets. We train all of our staff on making every contact count, so looking at how people can help themselves, how can we support self-care, and we do that regardless of clinical and professional background, and that goes from the receptionists to the consultants. So it means that you build different relationships, because trust is about relationships and forming relationships. In terms of those relationships, we invest an awful lot of time in those. I spend most of my time outside my own organisation, and I meet with all our partners at a senior level at least once a week, and we've been doing that for a long, long time. The other thing that we're doing is we've started looking at how do we develop services in a way which shares incentives and therefore also shares risk. And we're doing that in a stepped way, which means that we work together in looking at various issues which change things, and we hold each other to account. So what we've done is we've formed an incentive scheme which includes a range of measures, but all designed around emergency admissions in one area. And so we've looked at the impact of flu vaccinations in particular, for example, and as an organisation we've taken responsibility for flu vax, and by having that focus we've managed to become the best in London for the delivery of flu vax in the last year, and because that's involved all of our practices. We've identified some of the key enablers that we've got down there, and what we've done is we've got 3 live stream programmes, one for children, one for adults, general adults, and one for complex adults. And through a system of share and spread, which brings together different people, we've ended up boiling the ocean almost. We've got 60 projects roughly, which we've developed to change what we do as a system in Tower Hamlets. And I've listed some of those over on the right-hand side if you can read them. In particular, I think the ones which are really changing the focus and responding to patient need is nearly down the bottom. So our virtual CKD Clinic is where our patients are cared for largely by their GP, and the GP links with the consultant virtually to manage people. So remember, our residents won't go more than 500 metres. So how are we going to get them to the Royal London Hospital for their CKD review? Well, we don't. We now do that within their GP surgery, which makes a huge difference to what they do. One of the other things that we've done is we've got, I think I mentioned, 37 GP practices, and we've looked at how do you bring together and improve performance in primary care. So we've grouped our 37 practices into 8 networks. Now those 8 networks are geographically based, and they've been in place for a few years now. And what they've done, we've gone back one, there we go. And what we've done is we've then given them shared incentives which are linked to something called the Wharf, which is part of the payment mechanism in primary care. And that made that payable at a network level. So it means that we're looking to level up performance in individual practices. And what they've been doing is sharing their performance, looking at how do they improve together, and then being rewarded for collective improvement, which means that they've supported each other in that improvement. And as you looked at here, our levels when we started were pretty awful actually. When that's really a desired impact, we're doing really well. We're over 80%, but of course we'd like it to be higher. But in terms of the comparisons down here, you've got compared to England, we're doing very well. But also if you look at our neighbouring boroughs, so Tower Hamlets is the red one, that's us. Newham, City and Hackney are green, and then Waltham Forest, which is the orange dot down there. The neighbouring areas which are literally just around us, we're doing very well at. And that's really because of that network approach and that sharing and support which we've had individually. We've got a little bit of a dip going on, and I think that's because of the change in focus around the Wharf. And so we're now looking at locally what can we do. The next one is there because I thought it'd be helpful just to talk about another project briefly that we're doing, which looks at quality improvement with general practices. So we've got 23 of our 37 practices signed up to look at a quality improvement approach. So how do we support general practice in their surgery? And one of the things that they do is they design projects which are specific to their practice, but they then agree how they will share that across practices. And one of the problems that we've got, like everywhere else, is general practice and medical staff are becoming harder and harder to find. And so you need to use their time well, and you need to use that effectively. And so what we've done is looked at how do we deliver care and where's the focus of delivering care. And we've worked with practices around how they use resources, how they engage their patients, what are their outcomes like. And so over time what we've done is we've looked at how do we use e-consultation, for example, to change how a patient comes into the service, and also then who sees that patient, because they don't always need to see a doctor. They think they do, but they don't. And what this run rate shows is the number of calls which have gone to a doctor over a period of time and the impact of the QI on that. Now, as you can see, it goes up and down a bit, but again, generally, we've got a decrease in the level of doctor time for those emergency calls, and that's because it's not. We've been able to use different professionals and help people support themselves. We have a huge social prescribing program, which we're just evaluating. So one of the things, for example, that supports this, we have something called DIY Health, which works with parents to support their children if they're under 5, if they've got minor ailments, etc. And we're just about to launch an app and a website to help them further. But we bring groups of parents together and provide them with some support and then peer support on an ongoing basis to look at how do they support their children. So for me, briefly, I'd say if you want a good partnership, you need to invest in it, you need to spend time in it, and you need to try to make sure you build those human relationships, because trust is a very human thing, isn't it? It's about knowing somebody well, and build that trust through identifying shared goals and outcomes that you all can share, because you will all be slightly different focused, but it's that Venn diagram and where do you cross. Learn together, and then work together and build it up from there, using incentives and risk sharing so that you're encouraging people and you're rewarding. But lastly, recognise and celebrate the achievements that you have, because success breeds success. And if you show that working together well and makes a difference to your population, then you'll want to do more of it. So thank you.
Thank you, Tracy. I have to say I know Tower Hamlets very well. I lived in Hackney for many years when I was training. So it's interesting to hear what's going on. And we did our GP training out in Tower Hamlets. Okay. So I know the area well. Is there any questions for Tracy? Yeah. Oh, blimey, there's a queue.
Hi, Tracy.
Hi.
I had the pleasure of working at Tower Hamlets as a physiotherapist many years ago, so I'm very impressed by what you're achieving. I've got a question around the patient churn of 20% that you spoke about. How do you manage the fact that a lot of the patients that are going to be coming into the service are essentially always going to be new patients because they're just coming into the area? And the ability to mesh the social data and the healthcare data, how does that work with those new patients?
It's really difficult, is the answer. And if I refer back to the child deaths that I talked about, I find that a lot of those are because of churn. And so we are trying to improve how do we transfer and share information, in particular those which we identify as high risk, and have improved ways of sharing that. We're doing that outwards, we're trying to encourage that inwards, and that's about partnership spread again, and about how do you work with that wider partnership. We're also, again, looking at our population, we're developing something called the Tower Hamlets Health Club. And so we're going to have something which is for all of any person moving in Tower Hamlets, and through their employers and also online, etc. A Welcome to Tower Hamlets Health Club pack. We're centralising registration and centralising new patient checks. with GPs, so that we make it easy for people to access services and get registered and get checked on the list quicker, and so that then that enables us all to flag the risks as well. So that's one way we're changing. There is something in the UK which has been launched recently called GP at Hand, which starts to provide GP services via video using smartphones. So that's something else we're looking at. So it's about how do you provide services which respond and pick up people as they move into the area, and then make sure the information that you give when they move out is of good quality to wherever they're going to. But it's hard because people don't always tell you, etc. And so it's an area that we're trying to improve on, but those are some of the key ways. Okay.
Hi Tracy, thanks
Hi.
for that. I was very interested in your move to outcomes-based payments and how you were doing that and the success that you were seeing with it.
So for our, in particular, our community-based services, where a lot of the complex case management goes on, and we've agreed how we will identify that complex cohort in particular. And then what we're doing is part of the contract for those bills from start in year 1 5% up to 20% of that contract will be based on the achievement of the outcomes. And so those outcomes, though, don't necessarily exist in a way which you can identify as a baseline. So one of our first things that we've had to do is to largely through PREMs, so patient experience and patient-reported outcomes, start building that baseline for that cohort and that population, which we will then monitor and agree that we've started to agree the levels at which we agree the levels of improvement we should achieve. The ones that they're softer and they're more difficult to measure, so that's an area. The other ones are more like I showed here, so they're the outcomes in terms of the proportion of the population that needs to access care on an emergency basis is a harder outcome that you can clearly capture and measure. We're also looking at the length of stay in hospitals, because if you manage the care well and you support people on a social basis, including care support, then we should be able to reduce their length of stay. And I didn't bring that graph here, but we have got a statistical valid improvement in there as well around length of stay, because particularly for older people, you know, every week they spend in bed means that you get so much muscle deterioration that it's very hard for them to then get back up to their full potential. So that's another area that we've included in it, and we've got at the moment around 20 outcome measures that we're looking at, which say fit with what our population want to see. So we're trying to make sure we keep that in a manageable number to be reasonable, but it's linked to performance is linked to then payment.
Is that reflected in your data set?
Yes. Yeah.
Is it publicly available?
Our data set, the population health one, yes, we're sharing that. We produced a paper, it's online. I can make sure you have the links available.
Okay, thank you very much. It's very informative, really interesting to see how we in the Middle East can potentially take learning from this, because it is important. General practice is going to become more of a challenge in this region. We already see it in many parts of our region, including, although some of them will travel more than 500 meters, but I know in Dubai, 500 meters is a long way if your supermarket is more than 500 meters away. But there again, in Dubai, you can always get delivery. So, but thank you very much, Julie.
Thank you. Thank you.